Hello everyone and welcome to Blood and Hematology YouTube channel. The first video from Malignant Myeloid Disorders section is about acute myeloid leukemia. Definition, FAB and WHO classification, laboratory diagnosis and morphologic features of AML blasts are discussed in this video. Acute myeloid leukemia comprises a heterogeneous group of disorders that results from neoplastic proliferation and accumulation of immature bone marrow-derived, hematopoietic cells of the granulocytic, monocytic, erythroid, and megakaryocytic lineages. There are two classification systems for AML. The French-American-British classification and the World Health Organization classification. The FAB classification of acute leukemia was first published in 1976 and was subsequently expanded, modified, and clarified. The FAB classification includes a number of AML subtypes based on morphologic, cytochemical, immunophenotypic, and ultrastructural features. The FAB classification requires that peripheral blood and bone marrow films be examined, and that differential counts be performed on both. Using FAB criteria, acute leukemia is diagnosed if one of the following three features is present. At least 30% of the total nucleated cells in the bone marrow are blast cells, or the bone marrow shows erythroid predominance and at least 30% of non-erythroid cells are blast cells, or the characteristic morphological features of acute promyelocytic leukemia are present. Lymphocytes, plasma cells, macrophages and mast cells also being excluded from the differential count of non-erythroid cells. In the FAB system, AML are classified into 8 subtypes, M0 to M7. The World Health Organization classification is based on morphology, immunophenotyping, genetic, and clinical features. In the WHO classification, the blast threshold for the diagnosis of AML is reduced from 30% to 20% blasts in the blood or bone marrow, and also for some genetic categories, the blast cells threshold for diagnosis has been lowered to 10%. In addition, patients with some clonal and recurring cytogenetic abnormalities should be considered to have AML, regardless of the blast percentage. The 2022 WHO classification of AML builds on earlier classifications but with an increased emphasis on defined genetic or cytogenetic categories. AML without defining genetic abnormalities, categorized by differentiation and morphology. These subcategories are based largely on the prior FAB classification, and primarily distinguished based on morphologic, cytochemical, and immunophenotypic features. Laboratory diagnosis of AML begins with a complete blood count, peripheral blood film examination, and bone marrow aspirate and biopsy specimen examination. The initial diagnosis of AML relies on accurate interpretation of the cellular morphology of the bone marrow smears and the morphologic characteristics of the blast cells. The morphologic features of AML are diverse and vary depending upon the disease subtype. The peripheral blood picture is quite variable in AML. The total leukocyte count may be normal, increased, or decreased. Although the common presentation includes a variety of immature granulocyte forms, occasionally only myeloblasts are found on the peripheral blood smear. Abnormalities in cell granules and nuclear structure are frequent. Erythrocytes are typically decreased, and a hemoglobin value less than 10 gram per deciliter is common. The RDW often is elevated. Erythrocyte inclusions such as Howell-Jolly bodies, Pappenheimer bodies, and basophilic stippling, reflective of erythrocyte maturation defects, can be present. Nucleated erythrocytes can be present in proportion to the anemia or marrow damage. Platelets are typically decreased. Hypergranular platelets and occasional enlarged forms, or giant platelets, can be present. As the disease progresses, more immature platelet forms such as megakaryocytic fragments can be seen. Other abnormal findings on the blood smear often include monocytosis and neutropenia. Eosinophils and basophils can be mildly to markedly increased. Neutrophils can demonstrate signs of myelodysplasia including pseudopelgia cells, hypogranulation, and small nuclei with hypercondensed chromatin. Bone marrow testing should include both aspirate and biopsy specimens. Typically the bone marrow presentation is hypercellular with decreased fat content, a predominance of blasts, and sometimes an increase in fibrosis. Or rods and also dysplasia in the non-blast cells may be present. The enumeration of blasts in the bone marrow is crucial in the diagnosis of acute leukemia, and the definition of a blast cell is therefore important. A diagnosis of AML requires demonstration of 20% or more blasts based on a morphologic blast count differential, performed on an adequate bone marrow aspirate or peripheral blood smear. The following cells must be included in the blast percentage. Agranular and granular blast cells. Blast cells showing evidence that they belong to a specific lineage, such as monoblast and megakaryoblast. Promanocytes. Erythroid blasts in the rare pure erythroid leukemia, and promyelocytes with the specific abnormal morphological characteristics found in acute promyelocytic leukemia, including the microgranular variant. The following cells must not be included in the blast percentage. Dysplastic promyelocytes without the specific features of acute promyelocytic leukemia. Proerythroblasts, both normal and megaloblastic, or dysplastic. Micromegakaryocytes and other types of promegakaryocyte and dysplastic megakaryocyte. Atypical monocytes, recognized by their chromatin condensation and their cytoplasmic characteristics. In general, the blasts in AML are medium to large-sized mononuclear cells with high nuclear to cytoplasmic ratios, dispersed, delicate and fine nuclear chromatin, variably prominent nucleoli, and basophilic cytoplasm with or without granules or vacuoles. The FAB group define neoplastic blasts as type 1, type 2, and type 3. Type 1 has typical blast features without granules, type 2 has less than 20 granules, and type 3 has numerous granules. In the WHO classification, the blasts are divided into agranular blasts, corresponding to FAB type 1 blast cells, and granular blasts, corresponding to FAB type 2 and type 3 blast cells. The predominant cell in acute promyelocytic leukemia is a hypergranular promyelocyte. The cytoplasm is densely packed with numerous bright pink or red to purple granules, which can obscure the nucleus. The nucleus has a diffuse chromatin pattern and one or more nucleoli. The nuclear shape can be folded, kidney bean-shaped or bilobed with only a narrow bridge between the two lobes. Most cases of acute promyelocytic leukemia hypergranular variant are characterized by a cell with a reniform, bilobed, multilobed or convoluted nucleus and either sparse fine granules or apparently a granular cytoplasm. The nucleus has a fine chromatin and variably prominent nucleoli. The nuclei are characteristic because of their bilobed form, resembling an hourglass, a dumbbell or a mushroom. The monoblast is usually round and has an irregular cytoplasmic margin. The light blue to gray cytoplasm is non-granular or slightly granular, and cytoplasmic vacuoles may be present. The nucleus is round to oval, can be folded or indented, with a fine chromatin. There is often a single nucleus, but multiple prominent nucleoli may be present. A premonocyte is a large cell with an irregular or convoluted nucleus. The chromatin pattern is diffuse, and a nucleus may be present. The abundant cytoplasm is light blue to gray, containing scattered azurophilic granules and may be vacuoles. Megakaryoblast is a cell with high nucleus to cytoplasm ratio. The scant cytoplasm is basophilic, non-granular, and often with typical protrusions, or blebs from the margin. The nucleus is round to oval or kidney-shaped, with loosely organized chromatin and few prominent nucleoli. Or rods are abnormal rod-shaped or round pink to purple inclusion, composed of fused and condensed primary granules. Single or multiple OR rods may be seen in malignant myeloblasts and malignant promyelocytes. They are considered to be specific to the myeloid lineage, however they are not present in every case of AML, and may also be found in some forms of high-grade myelodysplastic syndrome. OR rods are not seen in normal bone marrow progenitor cells. They are positive for peroxidase staining, and even a single peroxidase-positive OR rod in a single cell of any type provides reliable evidence of a myeloid neoplasm. Composite image of peripheral blood smear from a patient with AML, showing single and multiple OR rods in blast cells. Thank you for watching this video. If you liked this video, to give it a thumbs up and share it. Do not forget to subscribe to the channel, if you still have not. You can click on the bell to receive notifications whenever a new video is uploaded.